Hi, and welcome to another episode of DTV. My name is Madison. I'm an Education Outreach Liaison at Doylshealth Health, and with me today is Dr. Heather Gottlieb, a urologist. Dr. Gottlieb, can you please tell the viewers a little bit about yourself, your background, and also what you do at the hospital?
Sure. Thank you for having me here today, Madison. So I'm a urologist. I work with Doylshealth Health Urology. I'm from the area. I grew up in Huntington Valley. I went to Gwen and Mercy High School and Villanova University. I did my med school and residency in Philadelphia. And then the only time I left the area was to go to North Carolina, UNC Chapel Hill, where I did a fellowship in neurourology and voiding dysfunction. When I came back to the area, I moved back to Philadelphia, and I was working for about 13 years at what is now called Jefferson Bucks Hospital. And a few years into practice, I moved into Newtown, so I'm local to the area. And for the past 2 years, I've been so happy to be a member of the Doylestown Health Urology practice.
All right, so what are some of the common conditions that you treat at Doylestown Health?
Yes, so like I said, I did a fellowship, so I kind of have a very narrow focus to my practice. I specialize very specifically in chronic urinary tract infections, pelvic pain, what is known as interstitial cystitis or bladder pain syndrome. I also specialize in urinary incontinence, and I also treat patients that have a neurogenic bladder.
So, as you said, neurogenic bladder, can you talk more in depth about that?
Yes. So neurogenic bladder, it's kind of a general terminology that refers to anybody with a condition, any type of neurologic condition that could affect the bladder. So for example, patients with Parkinson's or multiple sclerosis, even diabetes, or if you've had a stroke, if you have back pain, chronic back pain, or spinal stenosis, any type of neurologic condition can actually affect the bladder. And it could cause urinary retention, it could cause urinary incontinence, but basically anybody with a neurologic condition can see me for evaluation, and I can do very sophisticated testing to evaluate how their neurologic condition is actually affecting their bladder.
All right. So you also mentioned urinary tract infection. Can you explain exactly what that is?
Sure. So a urinary tract infection is just that. It's an infection that affects the urinary tract. So when we talk about the urinary tract, you're talking about the kidneys, the bladder, the urethra, and in men, they also have a prostate. So we think of the lower urinary tract as specifically the bladder, the urethra, and the prostate. And so when you get an infection, it can infect any of these organs, and it typically would cause symptoms of urgency, frequency, burning with urination, difficulty making to the bathroom in time. Sometimes a urinary tract infection can ascend to the upper urinary tract or the kidneys, and we call that pyelonephritis. That's an infection of the kidneys, and that can be more serious. It can be associated with back pain and a fever.
So would those symptoms be the same in aging patients?
So that's actually a very good point. So in elderly patients, we actually can see totally different symptoms. So sometimes the only symptom of a urinary tract infection is actually confusion, especially if a patient has a chronic Foley catheter or an indwelling catheter that drains their urine. They can literally just present with confusion or an altered mental status, and they can end up in the emergency room for that reason. So in those situations, we always want to check their urine and make sure that they don't have an infection. Other symptoms that would be kind of atypical, it could even be just a drop in blood pressure or even just a fever. So no burning, no blood in the urine, but just a fever or confusion. So that is a really important distinction because in a geriatric patient population, we certainly don't want to miss that.
Yeah, especially since those don't seem to be like those typical UTI
Correct.
symptoms that you would see. Okay.
Correct.
So you also mentioned previously that you treat interstitial cystitis.
Yes.
Did I say that correct?
Yes.
Okay.
Very good.
What is this and how is it different from a UTI?
Yes, so that's why we call it IC for short, by the way, because it is a bit of a tongue twister.
Yes.
So interstitial cystitis actually is a very large portion of my practice. And most urologists really don't treat it. So I do feel good that it's something that I can offer to the community here. Basically, itis means inflammation, and cyst refers to the bladder. So it's an inflammatory bladder condition. interstitial would be like the lining. So it's an inflammatory bladder condition that affects the lining of the bladder. And it affects women more than men. So 10 million Americans actually have this problem, but 70% of them are women. And we don't know why people get this condition. It often is related to stress, and there are specific dietary triggers. But the main issue is that people present as if they're having a urinary tract infection. So unfortunately, what happens more times than not is patients will keep bouncing back to either the emergency room or their primary doctor, or a lot of times they'll go to urgent care because they have burning and pressure and urgency, and they assume they have a urinary tract infection. And often the symptoms are related to intercourse as well. So a lot of times patients will just keep getting antibiotics, and they'll assume that they're getting urinary tract infections, and they won't always get referred to the urologist. So that is something that I specialize in the diagnosis and treatment of. The good news is that there is actually treatment. It is associated with some other conditions like irritable bowel and endometriosis and fibromyalgia. So if you have a lot of burning and pressure and urgency and you have those other conditions, that would certainly increase my index of suspicion. But if you do come to me with a history of chronic urinary tract infections, interstitial cystitis is always going to be on my radar, because typically patients, like I said, they'll just keep getting antibiotics and they'll never really get the actual diagnosis, so they get kind of misdiagnosed. And it's really a shame, because a lot of urologists, not only are they not really good at treating it, they almost don't believe in it, which is kind of silly to say. I mean, just talk to any of my patients and they will tell you it's a very real condition. But again, I think the important thing is just getting a diagnosis, so then I can educate patients and then I can offer them treatment if their symptoms are bothersome enough. But I mean, it really can be a very troubling condition. I mean, people basically always feel like they have a urinary tract infection. Now, they could have milder symptoms where they have flare-ups, where, you know, when they're under more stress, they have a flare-up and it kind of mimics a urinary tract infection.
So, how would you diagnose someone with IC?
Great question, and that's where one of the tricky things is as well. So it's one of those, what we call a diagnosis of exclusion. You know, there's no fast, hard, definitive test. So for example, if you come to me with a history of chronic UTIs, I'm going to track down your cultures and I'm going to make sure that you actually are getting urinary tract infections. Now, you could have interstitial cystitis and you could also get urinary tract infections, and that's tricky as well because you could have both. But the main way I diagnose is just taking a really thorough history, and then I do a pelvic exam. So when I do an exam on women, and although it definitely can affect men as well, but in women it's almost a little easier to diagnose because I can feel for tenderness on the bladder during a pelvic exam. And then I can also feel for muscle spasm on the pelvic muscles as well. I'll also check your urine, looking for blood or infection or other signs of inflammation. I'll do a bladder scan in the office, so I'll make sure you're getting empty. And honestly, a big part is ruling out other things. So I'll also always get a kidney, bladder, and pelvic ultrasound. I can look in the bladder, and we call that a cystoscopy. But unfortunately, a cystoscopy, that also is not definitive. And it's interesting because a lot of times patients will come to me after having seen one or two other urologists or one or two other urogynecologists. And when I bring up this condition of interstitial cystitis, and did anybody ever mention it to you, a lot of times they'll say to me, oh, I was told I didn't have that. They looked in my bladder, I don't have that. And unfortunately, looking in the bladder does not prove it. It can, in which case you're lucky, because now we actually did see the inflammation in your bladder, and I actually have a slide that is up that shows what that inflammation looks like. But you don't always see that inflammation. So looking in and having a normal bladder does not rule out interstitial cystitis, but if I look in and I see the obvious ulceration or inflammation, it can help rule that in. And the other thing that can help sometimes, and we don't always do this, but sometimes I can take you to the operating room and I can actually look at your bladder under anesthesia. Because in the office, sometimes it's painful because patients with interstitial cystitis, they have small bladders, they can't really hold a lot, they get very sensitive bladders when they do hold urine, and so they get that urgency and frequency. So we can take them to the operating room, and under anesthesia, it's much better tolerated, this filling of the bladder. And so we can fill the bladder for 10 minutes, kind of stretch it. And we don't even know why that's entirely therapeutic, but for some patients it can be not only therapeutic, but it can be diagnostic. So hopefully that gives you a feel. I mean, there are things we can do, but there's not one definitive test that proves it. So honestly, I usually make the diagnosis based on a really good, thorough history. I spend a lot of time with my patients, really trying to get a good history, and then their exam, and then some of the testing to rule out other things.
So is the treatment, will it clear up the IC or is it a chronic
Yeah,
condition?
that's another great question. So it is a chronic condition, and I try to explain that to people. It's not that that means you'll have it every day for the rest of your life. Usually it's good days, bad days, exacerbations, remissions. Sometimes people go into remissions for years. But I did mention that stress can bring it on, and then I don't think I mentioned the triggers. So I said it's related to diet, but the specific triggers are coffee, tea, soda, chocolate, tomatoes, oranges, spicy food, alcohol, anything with acid. So it's the same as the acid reflux diet as well. But again, the good news and what I try to focus on is it is treatable. It is manageable. There's no like cure per se where I can give you a pill and it's going to be definitively gone, but it is very, very manageable.
All right, well, great. So you also treat urinary
Yes.
incontinence. So can you talk more about that?
Yes. So in terms of urinary incontinence, which is basically leakage of urine, there's kind of two main types that I try to break it into because the treatments are so different. So the one type is what we call urge incontinence, which also is generally known as an overactive bladder. 34 million Americans have an overactive bladder. It's very common and it increases with age. So patients with an overactive bladder will have urge incontinence. They get the sudden urge to go and they literally can't make it into the bathroom in time. It's what we see these gotta go, gotta go, gotta go pills on TV. Oftentimes there's specific triggers. Like a lot of people will have urge incontinence when they go from sitting to standing. You know, they say, oh, I was fine, and then as soon as I had to get up to go to the bathroom, I leaked. Or we call latchkey incontinence, where you put your key in the front door and, you know, as soon as you get home, oh my gosh, you can't make it in time, you suddenly wet yourself. Also, running water is another common trigger for urge incontinence, where you're doing the dishes or you're about to get in the shower and all of a sudden you suddenly lose your urine. It can also happen at night. We call that enuresis, where you're sleeping and you literally wet the bed, or on your way to the bathroom because you wake up in the middle of the night, you leak on your way to the bathroom. So that's the one main type of leakage, urge incontinence. And then the other main type is what we call stress urinary incontinence. And when I say stress, we're not talking about, you know, worry and stress. We're talking about lifting and stress to your bladder, actual kind of mechanical stress. So people will experience that when they cough, when they sneeze. It's funny, a lot of people will talk about leakage when they're on the trampoline. And before I had children, I used to laugh about all these women that seem to have trampolines, but once I had kids, I suddenly had a trampoline. So it's funny, that's a common presentation. People are very unhappy that they leak either at the gym or specifically when they're jumping on a trampoline, because you generate pretty high pressures with those activities. And so that would be the sudden loss of urine with activity. You know, it could be going upstairs carrying the laundry. But there's a real distinction between those two types of leakage because it has to do with how we actually treat it.
So can you discuss some of those treatment options?
Sure. So with the urge incontinence, one of the first line therapies would be behavior modification. So we talk to patients about timed voiding, you know, watching those bladder irritants. They're actually the same. All those bladder irritants that I mentioned for interstitial cystitis also affect an overactive bladder. Coffee, tea, chocolate, tomatoes, oranges, spicy food, etc. So that would be first-line therapy. The other main first-line therapy, which I'm a huge fan of, is pelvic floor physical therapy. I'm actually really pleased to say that we now have 5 pelvic floor physical therapists at Doylestown Hospital. We actually didn't have any 2 years ago when I started, and even still they're basically booked out about a month because just so many people have these problems. But pelvic floor physical therapy is a wonderful, wonderful treatment option, especially if you don't want medicine. And so that would be kind of the main treatment after you fail, or if you fail behavior modification and physical therapy. And quite frankly, not everybody wants to do physical therapy. It is intimate. They do go in women in the vagina, and men it could entail going into the rectum. So it certainly is intimate. But I will tell you the physical therapists are so good at their job, and it really does work most of the time. So I always offer and recommend that first. But there is medicine, and there are a lot of newer medicines. I know sometimes people just don't want to take medication, but some of the newer medications are great. They have very few side effects. So medicine definitely is a real option for a lot of patients. And then there are procedures as well. So the least invasive procedure is what we call posterior tibial nerve stimulation. And I kind of liken it to acupuncture. It isn't actually acupuncture, but it's nerve stimulation to the bladder. And we don't even know exactly how it works, but it works very well for the treatment of urge urinary incontinence and also that urgency and frequency of overactive bladder, because usually they all go together. And basically what that is you come into my office once a week for 12 weeks, and the nurse or the nurse practitioner puts a little acupuncture needle into your ankle, and we're kind of tapping into the nerve that controls the bladder. So you literally have to come in for all 12 weeks. You know, if you don't get improvement at 8 weeks, we really do encourage you, because it could take all 12 weeks. And so after the end, and they're a 30-minute session, and you know, you can come bring a book with you or watch your phone or TV show. I mean, you're really kind of just in the room with yourself. The nurse or nurse practitioner puts the needle in, hooks you up to a little remote control, kind of like a TENS unit, if that's something that you're familiar with. And then at the end of the 12 weeks, if it does help your urinary incontinence, which it does about 70% of the time, so pretty good if you've actually failed medicine or other things. But at the end of those 12 weeks, if it did help you, then you need to now come back once a month for a maintenance. And that would be, you know, indefinitely until you choose some other option or do something else. But it definitely, for the right patient, it's a great option. More invasive, but similar to the posterior tibial nerve stimulation, would be a bladder pacemaker. I actually brought some of them with me today just to show to you. Basically, this is pretty amazing. The concept is the same. I mean, it's nerve stimulation to the bladder. And basically, this is a battery and a wire, just like a regular heart pacemaker. But with the bladder, as I mentioned previously with the other nerve stimulator, what the goal is to get this pacemaker actually into the nerves that control the bladder. So I can actually put a temporary one of these in the office, where I put a wire into the sacrum, and then you go home with it for a week as a trial to see if it helps your urinary incontinence. And if it does, then we can go to the operating room and make it a permanent implant. This one that I showed you, this is the permanent one. We don't put this in the office. In the office, it's just a milder, kind of like a little wire, but the concept is the same. So we put that in. If it works, then you can keep that in permanently. And they work very well. And the batteries at times can last all the way up to 10 to 15 years now. So that's a really good option. Just as a side note to mention to patients that might seem of interest to you, those pacemakers also work for fecal incontinence and urinary retention and pelvic pain. So in the right patient, sometimes it's a great option, even though it's invasive. You know, you might be able to kill two birds with one stone. So oftentimes it is a very excellent option. And then there is one other option for urge urinary incontinence, and that's Botox. So it's no different than Botox that you might get for migraines or for your wrinkles. It's all the same stuff. It's very safe. Sometimes it gets a bad rap, but it really is very safe. And that's something I can do in the office without anesthesia. Now, everybody's different. So if somebody didn't tolerate it in the office, we could always do it under anesthesia. The main downside of Botox is it wears off. So much like with wrinkles and cosmetics and migraines and everything else we use Botox for, it has a span of about 3 months to a year. Now, I would say, in my experience, on average, patients do get about 6 months. So if you're lucky, we could inject it into your bladder. We do that through a telescope called a cystoscope in the office. The needle goes through the scope, and then we literally kind of poke with the needle into the bladder. And then depending on what dose you get, you might get 10 pokes with the needle, you might get 30. But we do give you a numbing cocktail in the office first to try to make it as painless as possible. So those are all your treatment options for urge urinary incontinence, or what is often called an overactive bladder. For stress urinary incontinence, you could try the physical therapy. And for patients that have both types of urinary incontinence, which you absolutely could have both, you could go to pelvic floor physical therapy and potentially, again, kill two birds with one stone. So as you can see, I really am always a major proponent of pelvic floor physical therapy. But if the therapy does not work, then there are surgical options as well. And there's even one other non-surgical option that I want to mention. This is what's called a pessary, and they come in all sorts of shapes and sizes. They're basically little silicone rings that I can fit a patient for in the office, and I can literally put it in the vagina, test them right then, have them cough, make sure they don't leak, and you could literally walk home that day with a pessary. It's actually very rewarding if you have a patient that, it's like a faucet when they cough, especially in older patients that might not really want surgery. I have to say it really is very rewarding to put one in if it's fit properly and you do like it, meaning it's comfortable. So similar to women that have worn tampons, when they're in, you don't really feel that they're in, and if you do, you clearly don't use them. A pessary is that way. Ideally, it's in, you don't even know that it's in. So that's something that can be very, very beneficial for a lot of patients and can keep them out of the operating room. And then if those options don't work or you're not interested, there is surgery. There's two main types of surgery. A lot of people have probably heard of a sling. And slings have gotten a bad rap because they are mesh, but I will tell you that the American Urologic Association, as well as the American Urogynecologic Society, they all agree that a sling is really the gold standard for treating stress urinary incontinence. So the mesh is safe. And the mesh that we are no longer using is really mesh used to lift the bladder. And that's not what we're talking about here. This has nothing to do with a dropped bladder. It's stress urinary incontinence, and we can treat it with a little, very small piece of mesh. But when you put the mesh in, the goal is not to take it out again. And I have seen patients with even complications just from slings who seem to come in with this notion that they thought it could come out. So slings get put in without any intent of them ever coming out. We only really take them out if, unfortunately, there is a complication, which can occur even in the best of hands. It is a foreign body, and mesh can end up where it shouldn't be. But that's really the gold standard, and it corrects 90% of patients that have stress urinary incontinence. The other surgical option, which is a little less invasive, so some people might like this as an option better, it's what's called a bulking agent. So much like a lot of you have probably heard of collagen or bulking agents people get in their lips, we kind of do the same thing in the urinary sphincter. And again, it's a very minor procedure. I do usually take patients to the operating room. It's much more comfortable for you and for me. It's just a twilight anesthesia, really minimal anesthesia, but I go in with a little telescope. And then again, through the scope, I can put a needle in, and as the picture shows you and depicts, it kind of bulks up the sphincter muscle. So not everybody is a candidate for that. There are specific measurements and things I look for on exam to help decide who's a candidate for sling and who's a candidate for bulking agent. Everybody is usually a candidate with stress incontinence for a sling. It fixes all types of stress incontinence. Not everybody is a candidate for a bulking agent. So for various different reasons, and depending what I find on exam, you might be a candidate for any of those options. But at least hopefully the take-home message is there are options. I mean, you do not need to live with urinary incontinence. Most patients we can help.
All right, so we just covered a lot of information. So
Yes.
can you explain what a patient can expect when coming into your office?
Yes, and I'm glad you asked me that because most urologists, as I already mentioned, that they don't really do what I do. So most urologists don't do pelvic exams on women. So I do always like to give that heads up that you can expect a pelvic exam. Now, I don't do that every visit. So that is something I do the first visit to evaluate your symptoms. And then moving forward, it's actually pretty unlikely that I'm going to do it again unless your symptoms change or for some specific reason. But I do a pelvic exam. I use pediatric instruments. Most of my patients do have pelvic pain, so I'm very gentle. I use a lot of lubricant, so I hope people aren't, put off by that. But I do a pelvic exam at that first visit. As I mentioned, I'm feeling for muscle spasm and all sorts of different measurements and things like that. I also do a bladder scan. That does not hurt at all. It's just a measurement of whether or not your bladder is getting empty. And also, I should point out that I do treat male patients as well. Men obviously have things like pelvic pain and urinary incontinence, but in men, they do get a rectal exam and they also get a bladder scan. That's pretty standard fare. Thereafter, there is some other testing that you may or may not need done, and I would say those two main things are a cystoscopy. I touched on that a little bit earlier. A cystoscopy is just a look in the bladder, and basically it's a telescope, or rather it's like a catheter with a light and a scope on the end. And basically I have a monitor in my office, so you, the patient, can see everything I see. It's very quick. I mean, it takes about 15 seconds. I go in, I come out. You know, most people have had a catheter in their life, so I think you probably know, like, we put catheters in patients awake all the time. You know, it may be uncomfortable for one patient more than another, but generally, if I do a look in the bladder in the office, we do give you numbing lubricant first, and it really is not too big of a deal for most patients. Men have a longer urethra. I think it is, generally speaking, a little bit more uncomfortable for them, but it is quick. And if you don't want that done in the office, it can always be done in the operating room, but I would say 99.9% of patients do just fine in the office. The other thing that I might do, which kind of speaks again to my specialty and my fellowship training, I do really sophisticated bladder testing called video urodynamic testing. And basically, a lot of urologists do urodynamic testing. The video part is what makes this so specialized. And all it is that I use X-ray dye when I fill your bladder, so I can actually take X-ray pictures in the office. And I think I have a picture that actually is showing my room that you can see what it looks like, because it is kind of overwhelming. There's a lot of equipment. But basically, my nurse and I are there for this study, and we put a catheter into your bladder. It's a very small catheter. It's so small that you can urinate around it. And then we put a small catheter in either the vagina in women or the rectum in men. And then we can actually pump fluid slowly into the bladder, so we mimic the bladder filling. And then while I'm filling the bladder, I will take X-ray pictures, so I can look for urine backing up to the kidney, and I can look for the appearance of the bladder. And then we ask the patient, as we're filling them up, to let us know how full they are feeling. And slowly but surely, as you get to the point that you can't hold anymore, we allow the patient to urinate. And during that time period, I can still actually take pictures, which gives me a lot of information. So circling back to the neurogenic voiding dysfunction that we talked about earlier, for patients that do have Parkinson's or multiple sclerosis, this is a really wonderful tool that I have in my armamentarium that, to be honest, most urologists don't do. Typically, if you wanted a video urodynamic study, you need to go to Penn or Jefferson. So again, I'm really happy that's something we can offer to the community, just a very sophisticated bladder test. But those are tools. Not everybody needs a cystoscopy. Not everybody needs video urodynamics. But quite often it is something, usually before surgery. If we're at the point that you're failing medicine, you're failing therapy, you're kind of on a path towards surgery, I would say definitely before surgery. We like to know for certain what we're treating, and we want to make sure that we give you the best possible outcome.
All right. So you just mentioned your fellowship training, which was in neurogenic bladder. Can you talk more about that?
Yes. So earlier we kind of talked a little bit about how if you have a neurologic condition, any type of neurologic condition, that can affect the bladder. And we do generically call it a neurogenic bladder. So for example, if you have urinary incontinence and multiple sclerosis, we kind of assume, since it's the rule, not the exception, that the MS is affecting the bladder, and we call that a neurogenic bladder. But it's my job to figure out what specific type of neurogenic bladder you have. But for most patients, just to have that understanding of a neurogenic bladder, it's really just letting you know that your neurologic condition is affecting your bladder. And people with neurogenic bladder, and it can also include any type of spinal cord injury patient or spinal tumors, brain tumors. I mean, anything that affects the brain or spinal cord or peripheral nerves can actually affect the bladder. So a lot of times those are patients that will get referred to me, or if you have a neurologist or one of those conditions I mentioned is something you have, you may even want to ask your neurologist, because usually they are referring you to me. Patients with those conditions very often will have urinary incontinence or difficulty emptying their bladder.
All right. So if someone is interested in receiving care from you or your team, how should they contact you?
Yes, great. Please call the office. Our number is 215-230-0600. I will tell you that I work very closely with my partner, who's a urogynecologist, and I also have a nurse practitioner, Megan Blatz, who works with me. So depending on your willingness to go to one office versus another, I work out of 3 offices. I'm in Doylestown, I'm in Warminster, and I'm now in Wrightstown. They may offer you an appointment to see me, or again, depending on your insurance or which office you want to go to, or just in an effort to get you in as soon as possible. Sometimes they will offer you, if you want, to also see my nurse practitioner or my partner, Dr. Soriano. But generally, we'll just get you in as soon as possible. I do spend a lot of time with patients, so I do get a little booked out, but I always try to tell people, at least you'll understand, I'm going to spend a lot of time with you when you do come in.
Right, absolutely. Well, thank you so much, Dr. Gottlieb. That was super informative.
Oh, good. Thank you.
Right. Thank you.